Hello, everybody. Welcome to today's webinar. We are going to give folks a couple more minutes to join us, a minute or so, and then we are going to begin. All right, welcome everyone. I see a few people are still joining, but in low numbers, so we're happy to have you. Welcome to this month's virtual roundtable of successful public health approaches in dementia caregiving. Today, we will hear from Rhode Island and their work. Next slide. My name is Elva Johnson. I'm the coordinator of the Public Health Center of Excellence on Dementia Caregiving and also of the Center for Healthy Aging Innovation here at the University of Minnesota. Before we begin, we just like to take a minute here to ground us and acknowledge that the University of Minnesota, Twin Cities, is located on traditional, ancestral, and contemporary lands of the indigenous people. We appreciate with gratitude the land itself, the people, and we take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. And we hope to embed it in everything we do. A brief introduction of our center. Many of you already are familiar. We are the BOLD, PICO for short, Public Health Center of Excellence on Dementia Caregiving. And the mission of our center is really to help support and state, tribal, and local public health agencies nationwide in developing, kickstarting their dementia caregiving work and initiatives. And we do that in several different ways. We're the dissemination center by improving access to evidence-based programs, best practices, by helping facilitate connections and collaboration among public health agencies and their partners, like a session like today. And we provide technical assistance to individual public health agencies to help develop, ideate, and advance their public health programs and strategies related to dementia caregiving. And for a little bit of context, our center is part of the National Healthy Brain Initiative, HBI Collaborative, which is a multi-component approach to fully integrate dementia, cognitive health, and caregiving into public health practice. And it is made up of 7 organizations, all funded by the CDC, to work on the national HBI strategy. Our goal is to really inform it, again, provide public health approaches to expand collective impact on brain health. The collaborative is jointly led by the Alzheimer's Association, the CDC, and it's made up of population experts, which are our HBI components. The I2, or International Association of Indigenous Aging, focuses on American Indian and Alaska Native populations. The University of Illinois focuses on individuals with intellectual and developmental disabilities. And the Us Against Alzheimer's Center for Brain Health Equity focuses on Black and Latino populations. Together with them, there are 3 public health centers of excellence. We are one of them, hosted here at the University of Minnesota, focusing on dementia caregiving. The PICO on early detection is hosted by the New York University. And finally, the Public Health Center of Excellence on Dementia Risk Reduction is at the Alzheimer's Association. You can learn more about the collaborative at the next slide at hbicollaborative.org, or you can scan the code, and on that page that opens up, we will have links to look at all of the members of the collaborative. Thank you. Thank you, Maya. Next slide. So bringing us back to today's session, this is a virtual roundtable series.
But then I clicked on my volume button.
Thank you. It's a bi-monthly roundtable series for public health, where we are highlighting, as I mentioned earlier, the story of one state, the work they are doing. It is really designed for networking, peer learning, and idea sharing among public health agencies. And what we are really trying is to build a community of practice where agencies and everyone can really share their successes and lessons learned and build on each other's work. And yes, the slides will be shared. I see somebody put a question in the chat. So for the remainder of the session, as you can see, this is set up as a Zoom meeting to really facilitate communication. Please put yourself on mute. Thank you so much. But please, we encourage you to turn your video on. Imagine we are in a big meeting room and we are conversing as a group. Display your name and organization in Zoom. That really helps us to really know who all is in the room with us. And all of the questions that you may have for the speakers today, please use your Q&A feature in Zoom. You all should have it at the bottom of your screen. You can drop in your questions as you hear the speaker speak, and they will all be addressed at the end. And then when we get to the Q&A time at the end, please raise your hand. Use the reaction feature in Zoom to raise it, and if we invite you, please unmute yourself at that time. The chat, on the other hand, is used as that communication open space to share comments, resources. Look there for links from our speakers that they might be sharing with you, or you may decide to share relevant resources to what they're presenting with everybody else. Use the reaction buttons. Have a good time. Again, imagine that we are in a room and that network with one another, connect. And we will share the recording and the slides after the event. Thank you so much. And we are, before I hand it off to our presenters today, we would like to launch a poll just to give us an idea who all is here today. Please take a minute to respond. You should now be viewing the poll. Thank you so much. Answers already coming in.
Hey, $80?
Yeah, that's a lot though.
Please mute yourselves.
Do
Thank you so much.
you want to join?
Oh, great. I see folks introducing themselves already in the chat. Welcome. Thank you. Please, a reminder to change your name in Zoom and your organization as well for those who are just joining us. And I think the results are in. Maya, would you like to share them on the screen? And here are our results. Victoria and Haita. This gives us an idea of who is here with us today. We have 16 bold public health agencies and 20 other public health departments who are non-bold. And then the majority are community organizations, partners, public health agencies, that is, and caregivers and clinical professionals. Thank you. So, next slide, please, Maya. Thank you for responding to the poll. And here, without further ado, I'm going to hand it off to our amazing presenters today, who are joining us from Rhode Island, Victoria Parker, the program manager of the ADRD Rhode Island Department of Health, and her teammate, Haita Dimbalan, the program coordinator. Welcome both.
Thank you, Alma. So good morning, everybody. First of all, we would like to thank everybody for being here. We're so excited to be able to have an opportunity to share some of the work that we do here at the Rhode Island Department of Health. Next slide, please. So, as mentioned, We are the Alzheimer's Disease Program here at Rhode Island Department of Health, and today we will be talking to you about integrating quality improvement measures for better patient care. So we are a BOLD funded program, and we first received our funding in 2020. In 2019, we developed an Alzheimer's state plan alongside our advisory council, which consists of 19 legislatively mandated members. On a day-to-day, we work here at the Rhode Island Department of Health under the Center for Chronic Care Disease Management, which sits under the Community Health and Equity Division at the Rhode Island Department of Health. So some of the other programs that you would find within our center include programs for diabetes, cancer, and arthritis. Next slide. So here we have some of our high-level program goals listed, which align with the quality improvement goals that we have. Thank you. Next slide. So here we have quality improvement goals that we show how they align with our higher level program goals. So first we can start with early detection and diagnosis. So the quality improvement goal that goes along with this is increasing early detection by instituting quality measures focused on cognitive screening. We also have caregiver and care partner support. This focuses in on improving identification of caregivers as part of the healthcare team and documenting them in electronic health records, improving access and awareness of supports and services. Following this, we have public and provider education. With this, we integrate resources such as our provider toolkit and the brain health toolkit that serve as relevant educational tools. And lastly, we have data leveraging, which allows us to utilize data from electronic health records to measure success and drive our decision making. Next slide, please. So in order to achieve all of our quality improvement goals, we have convened a quality improvement collaborative. So what this quality improvement collaborative does is they help us in creating this goal statement. And for instance, here's the goal statement here. And this goal statement is primarily aimed at helping us identify our measures and also piloting measures in at least 2 primary care practices. Next slide, please. So in order to identify these measures, we have these key tasks, which include understanding the landscape of dementia, focused quality measures, selecting measures that align with our QI goals, and defining Rhode Island ADRD quality measure set. Before we could identify these necessary key tasks, we first had to ask ourselves the following questions. So we had to ask ourselves, what choices do we have with existing measures, and do they align with programmatic QI goals? Thank you. Next slide. So when piloting our measures, we had to identify the needs and potential barriers of implementing these measures, assess current primary care approaches to dementia care, recruit at least 2 primary care sites, identify quality team members and QI milestones, and support practice sites in data collection, including workflow process and electronic health record utilization. But in order to do this, we had to ask ourselves the following questions. What happens within primary care now? How will we recruit practices, and what support can we provide? Thank you. Next slide. So here we have our framework. We have been using this framework, and you will see that there are 3 functions that are starred here, and those are the functions that we will be focusing in on for today's presentation. And now I will give it over to Victoria.
Thank you, Haida, and good morning or good afternoon, depending on where you are. We're on the East Coast, so we're just at 11:45. Thank you for setting the stage for our presentation today, and thanks again to the Center of Excellence on Caregiving for having us. I'm going to jump in a little bit further to what this initiative really means, because it's pretty big and there's a lot to talk about. But we wanted to start with connecting to the public health function related to mobilizing community partnerships, because so much of this work is hard to do without partners. So we've listed our partners in our QI collaborative here on the screen. I'm not going to go through every one because you have it here, but the first 4 have been pretty significant in moving this work along. So the Rhode Island Alzheimer's Disease and Related Disorders Program is us, and we're excited to be here today. We've also had a physician consultant working with us who is a geriatrician from a hospital system in Rhode Island, who's really serving as a subject matter expert on measure landscape and sort of understanding workflow within primary care. The Rhode Island Geriatric Education Center is an academic-based partner out of the University of Rhode Island, and they are an agency that receives HRSA funding to support the Rhode Island Geriatric Workforce Enhancement Program, which you might have one in your state. They're frequently called GWEPs, and in Rhode Island, they facilitate what they call the Project ECHO, which we'll talk about a little bit more in the presentation. And also want to highlight the Care Transformation Collaborative of Rhode Island. I stole their mission statement right from their website because I think they explain what they do best. But they really have been our connection to primary care. And historically, they've had a lot of support in primary care transformation, including the implementation of patient-centered medical homes several years ago. So they've sort of reinvented themselves a few different times and have been really our connection to primary care sites. And then, of course, we have our state agency on aging, which we refer to as the Office of Healthy Aging, and CareLink, which is a community-based organization in Rhode Island. So just wanted to touch a little bit on who our partners are in all of this and who has been convened thus far as it relates to mobilizing partnerships. And on the next slide, we've told you about our program and our specific initiative involving quality improvement, and we've talked a little bit about our stakeholder group and their specific roles. So we wanted an opportunity to pause throughout the presentation to kind of ask questions and engage with the group. And our first question is essentially, why do you think something like this would be helpful? And if you want to respond, please put your answer in the chat. And I can certainly acknowledge when you've entered something in the chat. But in other words, the question is, what do you think the potential benefits are, or what comes to mind as you consider implementing healthcare dementia-focused quality measures? Potential benefits, how could it be helpful? And I'm just going to give a few seconds for you to think on that, and you can respond in the chat. Early diagnosis, definitely. That was one of our goals as well that we talked about earlier on. Program improvement. Okay, here we go. Giving data to support further investments, accurate diagnosis, increasing referrals, reducing stigma. All of this is great. Wonderful. If you can't measure, you can't monitor. Great motto. Wonderful. Lovely answers. Enhanced caregiver support and well-being. Great. So keep thinking, keep adding to the chat. I'm going to move to the next slide so that we don't spend too long here, but this is essentially our answer to that question. This is kind of our why behind our work. Most importantly, the top two being improving care for patients and caregivers and improving the patient experience, which ultimately leads to improved satisfaction. If you have an improved care experience with your primary care, you likely have a higher satisfaction rate, and potentially you're going to more appointments when you're more satisfied with your experience. And beyond improving care and improving satisfaction, we think that this is an opportunity to potentially improve fee-for-service billing and maybe inspire alternative payment models in the future by that tighter management of medical utilization when you're reporting on a quality measure. If you could go to the next slide. So this presentation, I think, would be kind of a miss if we didn't talk about the complexity of quality measurement. I know not everyone is an expert in this world. We certainly are not, and it's very complex. So there are payer-supported measures that primary care have to report on, for example, taking an A1C for a patient with diabetes. And what we have found is that a lot of the payer-supported measures don't necessarily focus specifically on patients with dementia, and some have pretty limited relevance for those patients that have that specific condition. So that's a bit of a limitation. And then there's another world that we like to refer to as HEDIS and CQA HEDIS measures, which again, don't necessarily focus on patients with dementia. HEDIS gets pretty close. They have a measure that they call Care for Older Adults. I think that has 4 components to that measure, which are advanced care planning, medication review, a functional status assessment, and a pain assessment. But again, not necessarily, specifically for patients with dementia. So going back to what Haida mentioned earlier on, about what questions did we have to ask ourselves? Well, one was just understanding what is available to us for dementia-specific quality measures. So the 3 examples that you see on the screen, Haida is going to drop a link in the chat to give you more information, because we could spend hours talking about measure specification, but we don't have that kind of time, and it could be kind of a dry presentation. So the first link that she's going to throw in the chat for you is a MIPS measure, specifically MIPS 288, which is called Education and Support of Caregivers for Patients with Dementia. And feel free to kind of jump into those links and look through the measure specifications if it's something you're interested in. The second example is through the American Academy of Neurology. They have identified 15 measure sets that look at patients with dementia. And they also have a caregiver measure as well that we'll be talking about in just a little bit. And also the RAND or ACOVE, Assessing Care of Vulnerable Elders. As you know, we love acronyms here. So another example of a measure set that could be helpful to you. Are you able, Haida, to drop those in the chat?
Sorry, just a second. I'm dropping them right now. Hopefully people are able to access it. Okay.
Great. And while you're doing that, I'm going to move to the next slide where we start diving in a little bit on the measures that we're looking at. So for the MIPS measure sets, we have found 4. We've identified 4 measures that we're potentially interested in implementing. They address functional status assessment for patients with dementia, depression and behavioral symptoms screening, safety screening, and caregiver referral to community resources, which includes both education that happens for the caregiver as well as a appropriate referral. And you'll be able to take a look at the specific measures in the link that we have for you. And then on the next slide, we're showcasing the American Academy of Neurology measures, which you see here. This is not all 15, but it kind of gives you a sense of what they're looking at. So we've also identified in the box some measures that align with the MIPS measures that we've identified. So both in MIPS and American Academy of Neurology, they are looking at functional status, depression and behavioral screening, safety screening, and also caregiver education and referral. You can also see, though, on the screen that the American Academy of Neurology goes beyond that, and they have measures that assess cognition, disclosing diagnosis and staging, med review, risks and benefits, and for antipsychotic meds, and also advanced care planning, among others. On the next, so this slide, going really deeper into the caregiver measure, because this is the Center of Excellence on Caregiving, we thought we'd want to kind of hone in on this measure specifically and also align it with the public health function of link to and provide care. So this is a measure description or specification that comes directly from the American Academy of Neurology. And you'll see in the description a few things. It is specifically for patients with dementia whose caregiver was 1, provided education, and 2, referred to an additional resource for support. So that is the sort of specific understanding of this measure. And on the next slide, we kind of go even further in defining what they mean by caregiver. So this comes right from their specification list. They identify and define what they mean by caregiver. They also define what kind of education can be provided. So you see here that it requires learning and processing information about disease management, health behavior changes, advising the caregiver about increased risk of illness to themselves, increased physician visits, use of prescription medications, emotional strain, anxiety, and depression. So the measure itself is saying, yes, educate the caregiver, but in the specification, they even take it a step further to say, here's the appropriate education that we see fit for this specific measure. And then the third component of the measure is about referral to appropriate resources. So they even define for us here what they mean by that appropriate resource. So they have that definition as a situation-specific tailored program to assist the caregiver, which includes national organizations like the Alzheimer's Association, or local resources like community-based organizations, senior centers, religion-based support groups, etc. So the specifications themselves can get really specific about what the measure definitions really mean. So just kind of giving you a sense of what that looks like based on the specifications. And thank you for putting those links in. So I'm now going to, we've talked a lot about the caregiver measure and the other measures that we're looking at, but we also recognize that with any quality measure, there are some limitations. So I'm going to hand it back to Haida to discuss this slide, and I'll just take a look in the chat to see if any questions have come up that I could respond to while you take over this slide.
Yes, so now we are going to discuss some of the limitations. So starting off, we would like to talk about how earlier in our discussion, we mentioned that one of our goals was identifying caregivers in electronic health records. And we've discovered that this has been one of the challenges because this measure doesn't necessarily provide that, or we have had challenges providing that. Following this, we realized that we need an assessment for caregivers to better know what matters to caregivers most. And lastly, how do we ensure that our referral systems are successful? How do we follow up after a referral is made to make sure that the person given the referral is reaching out? Did they schedule an appointment? And if they did receive services, did they experience any barriers? For instance, did they receive the services necessary in a language that they can easily understand? So we ask you to share any ideas or strategies you may have implemented to overcome similar limitations. And we ask you to help us answer the following questions. How have you tracked caregiver health and wellness? How do you measure what matters most to the caregiver? And what systems do you have in place to track referrals for caregivers and follow up on unmet needs? Feel free to drop any answers in the chat.
Rita and Victoria, it might be a little helpful to number the questions. So question 1, and folks can respond to each question, or would you like them answered in order first, or?
You can feel free to answer to any of the questions. Any order, doesn't matter.
I did see a question too in the chat from Charlene about materials available in Spanish or other languages, which is definitely something we'll have to work with our primary care sites upon implementation to ensure that they're holding the cultural and linguistic appropriate opportunities to communicate with patients and caregivers, but definitely something that has been on our minds. So yeah, I know we're posing a lot of questions to you right now, but one is really thinking about tracking caregiver health and wellness. One way I think it's possible to do that is by identifying caregivers in the health record, so that you can have, access to that caregiver and track their health over time, just as we do with other patients. and then measuring what matters most. You know, we've selected this measure about education and referral, but it doesn't necessarily get at what's truly important to the caregiver. So that's a bit of a limitation for us, and definitely want to see what people are doing to measure that with caregivers. And then the referral systems, like Haida mentioned, referrals can be kind of nebulous. You make a referral and then you lose contact with the patient, and it's hard to know if they got the support that they needed, and let alone if they got it, you know, in a culturally humble or linguistically appropriate way. So tracking referrals can also be a challenge. So I see some things coming in the chat. Looking at these exact questions about EHR development. So that seems like something that people would be curious to hear from folks on. Collateral electronic health record for caregivers. Definitely curious to hear more about that. Can caregiver health and wellness be included in a BRFSS question? That would be interesting. I think there are, personal opinion, a few limitations in the caregiver BRFSS. So adding something about health and wellness could be really interesting. Doing bi and multi-directional referral systems are helpful. Gary, have we in Rhode Island looked yet at international solutions? Not yet, but definitely an interest of ours, and that could be an interesting link to check out. And we could also readdress some of these questions further in the Q&A. I think we see a hand up. Are we able to unmute, or should we save that for the end, Alma?
If you think we're good on time, Victoria, I really like giving folks some more time to answer maybe in the chat, and maybe we can take that comment now.
Sure. Yeah.
I think some of these responses are really interesting and really good. Go ahead.
Perfect. Hi, this is Tene from Arizona. I think my referral question was related to if they're, should I say comment or question or anything? It was related to if they're current, because you guys say you're sitting within the bureau that also have other chronic diseases like diabetes and arthritis and all of those. I know in diabetes, because diabetes program is also under my leadership, I know for that, we have to develop like multi-directional or bi-directional systems for referral to DPP programs. I'm saying, can you leverage something like that to do your referrals through, and then you can track it that way? It's kind of what I was thinking. Or if you have similar things like, what's it called? We call it contexture, but it starts with a U. And Unitas, there you go. Unitas
yes.
also do referral systems as well. So if you can put it through there, maybe there's a way to kind of track your referrals for that. But for gathering data for caregiver, that's the issue. That's part of the reason why I'm on this call, to listen to see what people have, because that's the hardest thing. Breakfast is able to capture a little bit, but not so much on the wellness, more of like if they're being utilized. So
agree. Yeah, good questions. We do in Rhode Island have a centralized referral process that we refer to as the Community Health Network, which refers people primarily through primary care, but doesn't necessarily have to be a primary care referral. And they're referred to evidence-based programs, one of which is Powerful Tools for Caregivers. And we're able to get sort of bi-directional information about those referrals. But even understanding, if someone couldn't make it to the evidence-based program for a barrier that had to do with transportation or childcare or a social determinant of health, I think that is the information that we're missing in the bi-directional feedback. Even when we have those systems in place, it's hard to know, did they not go because they didn't have a ride, or did they not go because they needed to care for their loved one or something similar. So I think that's the level of information where we would want to be informed of to really make some community level changes and address some of those barriers. But thanks for your insights there. I'm going to move to the next slide, and then maybe we could come back to some of this too at the end, because it sounds like we're all very interested in learning from each other, particularly on the caregiver health and wellness piece. So this kind of brings us back to our original goal, which was related to measure identification. So on the screen, we put this visual together that kind of discusses the 4 measures that we are moving forward with on the outside, which are functional status assessment, symptom and behavior screening, and safety screening, as well as caregiver education and referral. And this is, if you can sort of follow the arrows, this is sort of trying to explain that by performing functional status assessments, by doing symptom and behavior screening, and by completing safety screening, you will inevitably identify unmet needs, both of the patient and likely of the caregiver as well. So by doing those 3 things, you can identify what the unmet needs are. And then with that information, you would be able to appropriately refer and provide education to both the patient and the caregiver. So this is bringing you to kind of what our second goal was actually implementing the measures. So you're probably thinking to yourself, like, how does this all work? So this is our pilot model for implementation. We have named it EQUIP ADRD. We threw in another acronym here, which stands for ECHO plus quality improvement. And I'll talk about ECHO a little bit on the next slide, but it is essentially a learning opportunity for healthcare workers, not necessarily just primary care, but learning for sort of the healthcare space in general. And then from a high level kind of view, moving into a quality improvement cycle where a plan, do, study, act cycle would happen within the primary care site. Primary care sites would get support from someone that we're naming a practice facilitator, and we'll talk a little bit more about what that role looks like in a next slide. And then sort of understanding that we wouldn't be able to really achieve this model without buy-in from primary care, as well as support from health plans. So on the next slide, going to jump in a little bit to talk about the ECHO series. And here's where we're aligning some of our work with the public health function of assuring a competent workforce. So if you're not familiar with ECHO, it is yet another acronym that stands for Extension for Community Healthcare Outcomes. It's a hub and spoke education model, all teach, all learn. And typically there is a didactic presentation followed by kind of a case study or case discussion. And it's meant to be sort of as interdisciplinary as possible learning experience for folks. So what we've done through our collaborative is leveraged our existing partnership with the Rhode Island WEP. They have an existing ECHO hub team that works to facilitate ECHO series all year long. So they have agreed to align their spring 2023 ECHO series with our quality improvement measures, which is actually launching in a couple of weeks. So the first session is going to be actually focused around the idea of the Institute for Healthcare Improvement, or IHI 4M age-friendly framework, because we think there's a lot of connection between the 4M framework and what we're doing within quality improvement. So we'll sort of kick off with that. And then the second session is going to be about best practice functional status assessment for patients with dementia. So folks who attend the ECHO are sort of getting that learning about what this measure means and what it looks like in practice. And they've agreed to align, that content with our quality improvement measures. And then we'll be recruiting the spoke sites across the care continuum, noting that it's not just primary care that's participating in this. And we'll also be providing a stipend to the participating sites who commit and to attending and also presenting a case study. So that is the first part of our implementation model. And on this slide, we're talking about kind of steps 2 and 3, which are the quality improvement piece and the support from a practice facilitator. So our goals in general here are to first identify the quality measures. So check, we've identified 4 measures that we think are pretty solid and want to move forward with. We'll also be developing a call for applications, which is how we'll be recruiting the primary care sites to participate in this. And that call for applications is going to be delivered through our partner the Care Transformation Collaborative so that folks can apply directly to this. And then we'll be recruiting them based on some selection criteria that we'll make up as well. We'll then offer support of a practice facilitator to the sites that we've recruited, and we'll be facilitating what we're calling best practice sharing meetings within the participating sites so that they can discuss, just as we're doing today, some of the limitations of the measures, what this still doesn't address for them, or hopefully successes as well and wins. And again, we're providing a stipend to the participating sites. So want to talk a little bit about the role of the practice facilitator because it's definitely key to the success of this initiative. And by no means do we think it will be easy, right, for primary care to actually implement the measure. So by giving or embedding a practice facilitator within their site to really oversee what that plan, do, study, act, quality improvement cycle is going to look like, we think is going to be a real value to them. So the practice facilitator is going to sort of be a subject matter expert on the measures themselves. They'll understand the nuances with the specifications that we looked at specifically for the caregiver measure. You can imagine, right, the other measures that we've selected have significant specifications. So they'll be meeting regularly with the implementation sites. They'll assist quality measure education on those specifications, just as we did today, looking at the caregiver measure. They'll develop quality measure milestone documents and kind of, again, helping with that plan, do, study, act, you know, by month 2, we should be here, and sort of helping them with that action planning, assisting with data collection and potential template building to electronic health records to really make sure that the data is collected consistently across sites, identifying any workflow changes that might happen as a result of implementing the measure, and then in general, problem solving and again, best practice sharing. So that is sort of our practice facilitator role, which we think is going to be really helpful to the success of primary care implementation. So going to pause again here because we've done a lot of talking, but wanted to ask a little bit about specifically that practice facilitator role. And if you are working with an equivalent role that helps you with any sort of health system interventions. I think like what comes to mind for me is a community health worker or dementia specialist of some kind that you sort of embed within your health system interventions. And if you have any lessons learned, what kind of supports can they provide? And how could this role be expanded potentially to identify caregiver needs or provide caregiver support? So let me pause. I see a couple of questions in here. One asking about how HIPAA works with all of this. So the measures themselves in the electronic health records are staying within the primary care sites, and they'll then be reporting out to us what their outcomes were or how the quality improvement cycle is. So there is no sharing of data outside of someone's electronic health record, which I think is helpful and helps us avoid any issues with patient information sharing other than the reporting templates that we'll build for the implementation sites. And there's a question here from Bonnie. Do you use the GSA KAER toolkit as you work with primary care sites and caregivers? That is an acronym that I do not know, so I'm not sure. Care team navigators has had great success over the past 8 years. Wonderful. That role of a navigator. Anybody else have an equivalent role or a health system support role? Increasing dementia education as part of CHW training or community health workers. They're crucial in cultural outreach. Definitely true. Is this limited to Rhode Island physicians? Hopefully not. Hopefully other states are interested in doing some of this work. would be wonderful to expand. Did this project have IRB review? We have not done an IRB review process. The Alzheimer's Association has a program to help health systems expand their dementia capability. So it's like a great resource. One question from Pam here. Will the practice facilitators meet with each other to discuss challenges across the sites and the ways that some sites have addressed those challenges? For the moment, we have one practice facilitator who will be helping to support at least 2 sites. But in other models, I think someone else had mentioned earlier the diabetes program. And within the diabetes program at the health department, they have a very similar model that involves quality measure implementation with multiple practice facilitators. And during their best practice sharing meetings, those practice facilitators come together to talk about lessons learned, challenges, limitations, barriers, successes as well. So definitely as this continues and hopefully expands, the practice facilitators would engage with each other. State of Wisconsin has a dementia care specialist in every county. That would be a dream, to provide support and education to those with dementia, their caregivers, and the community. I have heard a little bit about that model in Wisconsin. It sounds wonderful. And cultural health navigators, CHWs, also looking at how your pharmacists could be leveraged. That's a really good idea. Great. Thanks, Elma, for following up there on Wisconsin. We had a grant that supports our health system initiative, caregiver support. This is through the Administration for Community Living. Our 2 interventions are Savvy Caregiver, wonderful, in Indian Country, and Music and Memory, great evidence-based programs. Some review. Oh, good. Okay. Thank you, Gary. The KAER toolkit, and thanks for including that chat there. That's helpful. Okay, let's move to the next slide. And I'm going to let Haida talk a little bit about our primary care engagement.
Okay, so in the hopes that our quality improvement work would be the most effective, we held informant interviews with 4 primary care organizations here in Rhode Island, and we asked them these questions. And we asked these questions in the hopes that we could better understand what challenges they're facing and what approaches they are using for both dementia care and quality improvement implementation. Next slide, please. Okay, so for instance, these are 2 of the questions that we did ask these primary care practices. The first question is, how do you or your practice view patient populations with dementia, and what are the current or potential challenges in managing this population? So we asked them these questions so that they could identify some challenges that they are facing, and this is what they shared. They mentioned canceled and missed appointments, behavioral symptoms, unsafe behaviors, challenges or difficulty in daily activities, managing medication, and caregiver stress and burden. So with having had conversations with the primary care practices and seeing that these were the challenges that they identified, we realized that the measures that we chose are actually quite fitting and suitable for these practices to address their concerns. Next slide.
And this is wrapping up our implementation model. So if you remember back a few slides ago with all the different colored squares, our last piece of the puzzle was related to getting support from health plans. And we think that can be helpful in just general sustainability of quality measure implementation. Often these quality measures are payer supported, so having their support on that would be really helpful in sustaining this. Additional funding for implementation sites is something that they might be interested in providing in terms of advancing this work. And then also thinking how this could potentially shift payer mandated quality measurement in understanding that patients with dementia are high need, high cost, and pretty complex. So to me, it's interesting that a measure isn't more readily available or isn't already sort of required from payers, particularly addressing patients with dementia. We have had some luck in doing this. United Health Plan is a health plan in Rhode Island that has been a part of our quality improvement collaborative and has been engaged with us in the identification of measures, and also has had some perspective on what our implementation model might look like. So they've been a really helpful partner, and one that we don't often think about in terms of mobilizing partnerships. So this is sort of our final slide for you, which hopefully gives you some sense of where we're headed. So our next steps in the immediate future will be to launch Project ECHO, which is our learning opportunity that is sort of funded and supported through the Rhode Island GWEP, or the Geriatrics Workforce Enhancement Program, that launches on Thursday, March 30th. So we're looking forward to that launching and kind of building that learning opportunity. We'll be further defining the role of the practice facilitator, and you all had some really good ideas about what that role might look like and some of the activities that they do within your states. We're going to recruit the implementation sites, so we'll do that by developing the call for applications and likely develop some selection criteria as well to think through how could we choose a primary care site that's going to have the most success in implementing the measure. And then developing the implementation plan with our quality improvement collaborative group, continuing to convene them and connecting with our practice facilitator. And wanted to sort of leave you with some hopes for the future about, kind of 5, 10, 20, 30-year view on some of this work. Continued buy-in from all of our partners is definitely a priority for us. Identification of a measure that addresses detection and diagnosis. The measures we've selected so far have been focused on patients who already have been diagnosed, but we know that there's a gap in terms of detection. And we think it could be really helpful and interesting to implement a measure that really looks at identifying the diagnosis and detection. And then also developing a mechanism to gather feedback, particularly from caregivers and patients as the measures are implemented. So that's sort of a check to ourselves of, we think this is a great idea. We think these measures are going to have a lot of success and potentially improve care, but we do need to figure out a way to get some feedback from patients and caregivers who are ultimately impacted by the measure implementation. And I'll also add getting feedback from primary care sites. Definitely want to keep the lines of communication open as we implement these measures to think about potential barriers or solutions to some challenges that they've identified. And then also utilization of lessons learned to impact dementia care infrastructure in Rhode Island, potentially identify alternative payment models, and also support care management moving forward. So with that, we've left our contact information here. This is definitely something that we're excited about and like to showcase. So if there are anyone who wants to follow up with us about this work and has more specific questions, we'd be happy to meet with you, preferably after next week when the BOLD application is due. But we'd be happy to chat with anyone who might be interested. And I think that brings us to the end of our presentation. So thank you so much for listening to us go on about this really exciting project. And I think we'll open the Q&A.
Thank you all for joining us.
Wow, what a great presentation. Thank you, Haida. Thank you, Victoria. There's been so much conversation and in sharing here in the chat. It sure is a great tool to have. We will be sharing the recording, the slides, and also the chat content because there's quite a few useful ideas and links with everybody after today's session. We have 2 questions here in the Q&A, but we can start with those. And then how about we go to that slide you had with those 3 questions before, in case if you would like to pose them again to the audience.
Great.
Would you like to do that? Victoria?
Sure. Yeah, I just can't see the Q&A.
Yeah, what we have in the Q&A, Jasara Winskowski, I hope I pronounced that correctly, said, I measure what matters most to the caregiver by assessing their goals of care, their values. What does safety and their support system look like? Do they have a support system? I assume this is in the EHR, in the healthcare setting, Jasara, and that you were sharing, is there a question here for the team? Well, if you're still here with us, I know a few people have dropped off, but if you're still here with us, please do maybe restate the question. I am just not clear. And then the other one is, do you use bold funds to support the practice facilitation and ECHO? And if so, what is the cost? And by the way, best of luck in your bold application.
Thank you.
Thank you. We do. So the ECHO actually, though, is supported through HRSA funding that the Rhode Island Geriatrics Workforce Enhancement Program receives. So based on our partnership with them, they fund the development and facilitation of the ECHO. What we have been funding related to the ECHO is building evaluations for each session, coming together and billing for time that it takes to think through what kind of questions we want to ask, what type of subject matter experts might we want to recruit, but they really are responsible for carrying out the work of the facilitation and the development of each session, which is really helpful because it just builds capacity for us to actually implement this program by including an ECHO that we don't necessarily have to have full responsibility over. And we also don't have to provide a lot of funding to support the development of the ECHO. A lot of our funds goes into paying for our physician consultant to be a part of our subject matter expert team and utilizing that relationship, as well as a contract with the Care Transformation Collaborative, which is sort of our connection to primary care. They're the health system partner that has done a lot of integration work with primary care and has led a lot of primary care transformation. So using our bold funds, we subaward out to that agency, and they are the ones who oversee the practice facilitator, develop the call for applications, recruit the practices, provide the stipend. So they fill the role of a lot of that work, which we would not be able to do without them. So they're definitely a key partner in all of this. Off the top of my head, I think the question also asked for a contract amount. I want to say our current contract with the Care Transformation Collaborative to carry out a lot of that work is to the tune of around $60,000.
Thank you, Victoria. Before we go to these questions, is there anything, any lessons learned, anything you would like to share, or key takeaways with public health agencies who have listened to you or who are doing similar work or would like to begin similar work? Anything that you would like them to know?
Yeah, I think part of it, the biggest lesson for me has been how complex this is. It's really hard to say, like, our goal statement is identify measures and implement the measures. That sounds so easy in a goal statement, but really diving into this has taught, I think, both Haida and I how complex this world of quality measurement is, what it means, what the implications are for primary care, and knowing that, we're just in the beginning phases of this. We haven't actually moved to implementation yet. We're sort of figuring out the best way to do that, but just understanding that there will be more lessons to be learned, and it is going to be more complex as we move along. So it's definitely not something that you can just, I'm going to do this in 6 months and it's going to be great. That's what we'd like to believe. But I think a key takeaway has just been the time and the commitment that it takes from our partners to really establish a process that we think is going to be successful.
Yeah. Great. Yeah, there sure is a lot to be worked out in terms of the healthcare provider, and everybody's workflow. I mean, in the EHR, beginning from even identifying the caregiver and then documenting the caregiver need. I think it was Tiffany Robb who mentioned in the chat earlier, she mentioned collateral EHRs. That would be interesting to know what those are. Are those new EHRs, or is this a connection to an existing electronic health record of the caregiver? Yeah, it sure is. And the new roles that you mentioned, this practice facilitator role is so key to help make all those connections and the follow-up always. Yeah. Yeah, well, I will let you actually guide this, the next few questions. Is there something that you would like to learn from the audience? Any questions you would like to pose?
We did have one question in the chat about how large our ADRD program is, and you are looking at us. It is myself and Haida, so we are a team of 2. We also have some support of an evaluator, which is very helpful, and then we fund a position outside of the Alzheimer's Association to do some community engagement. So we use our BOLD funds to support a contracted position within our Rhode Island chapter at the Alzheimer's Association. And then our sub-awards go out to contracts that, as you can see, really build the capacity of the program. Like, for example, the practice facilitator role, which we fund with BOLD dollars. But I will hand it off. Oh, Gary.
Thanks, Victoria. I had put a question into the Q&A that I don't know if I might not have done it correctly, but first let me just thank you for your leadership in the state. It's really exemplary, and thank the Center of Excellence for inviting Rhode Island to present. My comment, and then the question I put in the chat, my comment is that it's so smart to begin with quality measurement, and then to have the practice facilitator be coaching the sites to align with the quality measures. It's just, we often think about implementing evidence-based programs and then using the quality measures to assess that program implementation. And this takes it from another perspective to have the primary care infrastructure and service delivery improve in response to aligning to quality measures. So it's very smart. And then my question about that, it follows up on another question that was in the chat about whether there would be more than one practice manager and if there would be some type of community in which they would meet with each other to share what's happening around the state. And then a question that I added about the practice managers doing any coaching regarding evidence-based intervention separate from their coaching about quality measure implementation.
Yeah, it's a good question. I feel like we put a lot of responsibility on this role of the practice facilitator and practice managers as well. But I think what we'd like to envision as this sort of continues and advances is that the practice facilitators would engage with each other to some degree, lessons learned, what's happening within your practices, how could we learn from each other? And then potentially expanding that role into somebody who sits within and identifies workflow changes that could connect to community-based organizations, for referral sources, could identify community clinical linkages, particularly to address social determinants of health, because so much can be managed within primary care, but often not access to transportation or housing or food insecurity or challenges like that. So that's another idea that we've had as a way to sort of expand that role, is identifying those community clinical linkages as well. And then and community-based organization referrals could also mean referral to an evidence-based program like a Powerful Tools for Caregiver or Know the 10 Signs or an Alzheimer's Association community forum that is happening. So I like to imagine that this role is going to do all of those things. I think we're asking a lot, but I definitely see the need. And if this is someone who can assist with things that happen outside of the walls of primary care, we'd get, sort of the most value out of that role. So those are just some ideas that we have about how to kind of expand and enhance what that person could bring to the table as a practice facilitator.
Thank you. That's excellent. So they're operating at the level of system change, not at the individual caregiver level, but by the system change, then they get the implementation at the individual caregiver and patient level to operate more effectively.
Definitely. Yeah. Yeah.
Thank you.
Thanks for your question.
So Victoria, we do have more questions here in the chat. One of them, DNR and tube feeding are a part of the advanced care planning, but in dementia, hand feeding is not addressed as part of advanced care planning discussion. Hand feeding can cause aspiration and pneumonia, and persons may not want caregivers to spend hours hand feeding. How do you raise the question of hand feeding in dementia and address end of life care in dementia?
That is a good question, and it is exactly why we have allocated some funds to have a physician consultant on board with us as we move this work forward, because as measures are implemented, I suspect that there will be questions on what really is best practice for a functional status assessment or some of the other measures that we've looked into. And while I think we could provide some level of information about what best practices, we're really relying on the knowledge and expertise of our physician consultant to sort of lead that process for us and respond to some of those questions. In addition to that, we have our quality improvement collaborative group, which right now has been very focused on, identifying measures and identifying the implementation model. But there is a world in which I could see them really expanding into sort of that community of practice that answers questions like this, that identifies what best practices are, that really becomes a leader in the state and with primary care to kind of answer and address some of the discrepancies or some of the challenges that we are reminded of in terms of best practice. So I don't have an answer to your question, but definitely that's why we've included some specific subject matter experts in our work. I do see another question. What are the duties of your contractor that works with your local Alzheimer's Association? So I mentioned, and you might not have caught it because it wasn't on the slides, but I had mentioned that we fund a community engagement coordinator at our local Alzheimer's Association chapter. And what they are hired to do is connect with our priority populations in the community and essentially bring the resources and information that the Alzheimer's Association shares to those pockets of the state that are traditionally underserved and kind of are identified as our priority populations. So that is their specific role, is really integrating within the community and pointing out and creating specific relationships that advance health equity and bring valuable information and resources to those communities. And they've had a lot of success doing that. The person that we hired as a contractor actually used to be a community health worker. So that's another way of thinking about how to integrate community health workers into your programs.
We also have another question. Are these implemented mostly through federally qualified health centers and lookalikes? If yes, have they mentioned being short-staffed? We hear a lot about, we hear a lot about that from PCA regarding burden on federally qualified health centers to do quality improvement projects like these.
Yeah, so we do have a few federally qualified health centers and community health centers in Rhode Island that we'd like to expand and implement with, but we do hear the same challenges about short staffing and burden, among other things, and also coming out of a pandemic. So definitely recognizing that as a challenge. We have not yet recruited sites, but we do have one site that's interested in being an implementation site, and that is the Rhode Island PACE program, PACE. You might be familiar with PACE. It is an alternative model of care. They serve as both the health plan and the healthcare provider, and they have an interdisciplinary team and an adult day center and a health center on site, among other services and supports. So that is one program that has been really interested in implementing this within their within one of their PACE sites in Rhode Island. But definitely would like to advance into federally qualified health centers and recognize all of the burdens that they are facing for sure. And thank you for addressing some of the hand feeding questions. Yeah, I like this idea, Helen, about an ADRD task force, engaging nonprofits, elevate, share support options, alleviate duplication, definitely needed. Thank you, everyone. So it's about 12:40. How are we doing on time, Elma?
We're doing great. Yeah, please, we still have 20 minutes. If there are any other questions, or if anybody would like to share similar work or ideas or roles, for example, roles similar to the practice facilitator, how they've been leveraged in similar contexts, please do share, raise your hand and share with the rest of us here. I mean, I would like to ask a question about caregiver identification and thinking about the clinical flow and the providers working and with EHR. What have been some main challenges with identifying caregivers and how have those been overcome? What has worked well? Have you seen to systematically identify and track caregivers' needs as well as part of dementia care?
Yeah, I think it's a challenge that many of us have questions about and would like to do. For the practices that we have worked with who identify caregivers to some degree, not every practice is going to be able to set up their electronic health record in this way. And I think that's part of the barrier, is the differences in EHR templates and what that looks like across sites. So that's part of it, of the challenge. But for some sites that have been doing this, finding it helpful to understand what's happening with the caregiver over time is a benefit to their program. And by implementing this measure, it's not necessarily identifying a caregiver, but hopefully there would be some documentation of, I've provided education, I've given this referral, and then to follow up on that at the next visit would be a goal of ours in implementing that measure, which I think would take some level, right, of documentation. Did you want to jump off mute? Is it Tenna?
Yes, it's 10A.
Okay.
So sorry, I have a quick question. Does Rhode Island, and it's interesting because I actually came from Rhode Island before I moved to Arizona. I actually went to Shea High School in Pawtucket. So you guys hold a special place in my heart.
Love that.
So my question is, does Rhode Island, do you guys, at the Department of Health, do you guys work with your county health departments? Like your county health departments on some of these initiatives? Because here's the thing, Arizona is really large, and some of our counties have like a healthy aging program manager to work on some of these, and some of them don't. And they're asking us at the state to provide some of this level of data or like guidance or mentorship or something like that. But we don't even have a staff here at DHS that kind of works on that. I work on that in addition to all my other things that I do in my role. So I was wondering, how are you engaging your county health departments, if any? Are they involved in this? And yeah, I would leave it as that.
Yeah, so in Rhode Island, we have one public health department. We do not have local health departments or county health departments. So we are the smallest state in the nation, and we only have one public health department that oversees the entire state. But with that said, there is an initiative out of our health department called the Health Equity Zone, or the HES initiative, which identifies specific zip codes that are traditionally underserved, or we identify them as our priority populations. And that community comes together to create an action plan on different items that they might want to address. For example, some of them want to address opioid crisis, food insecurity, access to healthy foods, housing issues, behavioral health. So we've integrated as much as possible with that collaborative and using the health equity zone model to sort of push forward some of this work within the community. It's hard, I think, in general, to connect with that community-driven response, which is really focused on what's happening in that specific zip code, and bring to them, but what about dementia? What about Alzheimer's disease? You know, you should be thinking about this too. So we've done our best to sort of integrate and communicate, increase awareness, but it's definitely a challenge. And I would say that we rely more on our community partners that you saw in our collaborative to really push some of this work forward. But the health equity zones are one area that we could do a little bit more, increase awareness within those resources, within those partners, to sort of push some of this forward. Unfortunately, we don't have the county level or the local level health departments.
I wonder if anybody in the audience, if we still have any state health departments who would like to maybe try answering this question from their perspective. Is there anybody else in the audience, any state health department who could speak to this? Rotena? Please feel free to raise your hand. It can be local or tribal health departments. Okay.
So, in the meantime, we did have another question in the chat about what is the purpose of early detection and diagnosis for dementia? Well, some of the things is just being able to be proactive and kind of being able to get a step ahead on treatments and better understanding the symptoms or taking necessary action steps with disease management. So that is definitely one of the main advantages of early detection and diagnosis. And this can even help to delay some of the symptoms that could happen with Alzheimer's disease and other forms of dementia. I don't know if you have anything else to add, Victoria.
I'm willing to bet that there are others on this call who could also answer this question if anyone else wants to jump in here on the purpose or potential benefits of early detection.
Can we get a link in the chat to the Early Detection Center of Excellence? Elma, maybe you could do that.
Yes, I will drop it.
Cool.
Oh yeah, it's there. Thank you, Nick.
Yes, apologies. I'm actually meant to reply to the mention in the chat. My name is Nick Mirren. I'm the research and program coordinator for one of the other public health centers of excellence that's dedicated to the early detection of dementia. So we have our own program website where I have dropped a link to one of the tabs that goes over some of the elements of an early detection approach. There's also a toolkit that we have put together as a center that is dedicated to providers operating within a health system environment in terms of how to navigate the early detection process, both as a provider situated within a health system with billing codes and reporting obligations, but also a need to provide supportive follow-up services to patients. So a big element of the benefit of early detection, as Haita touched on, would be to connect impact the patient and caregiver and the broader family, yes, with supportive resources and elements that can facilitate behavioral and lifestyle adjustments as disease, it slows disease progression, but also as the disease progresses, to have a better sense of how that might manifest and how to respond to the changes. But be glad to discuss this issue in more detail. I can put the email of our center, and we have two center leads who are very familiar with the etiology of the disease, as well as dementia as a population health concern. So I'd be glad to discuss that further.
Thanks for jumping on, Nick. The Center of Excellence on Detection has also been really helpful in kind of framing our implementation model, and especially as we think about implementing a measure that is specific to detection and diagnosis. I'm sure that there will be a lot of resources to come, certainly from that center as well. Helen?
Hi there. I'm Helen Metzger, and I'm actually not with any state or agency work, but I'm a caregiver representative on the Health and Human Services NAPA Advisory Council. I also do work globally through the Global Brain Health Institute and a variety of others. And I've been in this battle for over close to 35 years, because I've had 3 first-degree relatives who have succumbed to Lewy body dementia. And I'm an absolute advocate for early detection and differential diagnosis. It is essential, especially in my population, because we can improve safety, we can improve quality of life. Early detection also helps the families to chart a path, obviously, to the discussions around both financial well-being, end of life discussions, those things. And then I tell them, it'll be an evolving process. Put it in a box for now, but know that it's done. And you can change it as need be. But more importantly, it helps the families to enjoy their lives while they can, to in many people's cases, a lot of the advocates I work with worldwide are people affected by a variety of dementias, and it gives them a sense of purpose while they still are healthy enough to engage. Many of them are advocating at governmental levels, at organizational levels, and making a huge impact. So there is profound benefit to early diagnosis. And in Lewy body, we respond better to many of the therapies along the cholinesterase inhibitors that even Alzheimer's doesn't respond as well to. So the earlier they're on those medications, if they respond well, they will have extended and higher quality of life. So it's a profound reason for early diagnosis and accurate diagnosis. Thank you.
Thank you.
Thank you, Helen.
Thank you, Helen. That was a great answer. Thank you so much. Any other questions from our Rhode Island team to all of us, or from all of you in the audience? There's a lot of exchange here in the chat. I encourage you to take a look. And again, we will record it and send it along with the materials from today's webinar. Yes, it was fantastic. Thank you, Haida, and thank you, Victoria. That was great.
So much. Thanks for having us. It's been really exciting to work on this initiative, and happy to chat with anyone offline as well if they're interested in hearing more as we progress. So thanks so much for the opportunity.
Yeah, and it was so great to see our BOLD community members, other BOLD public health programs here, and many others who haven't at least yet received any BOLD funding. So this was great conversation. And also my colleague Maya put in the chat a link for a brief evaluation survey. It's very important to us that we know about your experience, how we did, and other topics that you would like us to work on related to dementia caregiving and public health strategies to advance it. So please take a minute just to tell us about your experience. Oh, question, what is the difference between BOLD, public health, and public health? From Mozilla. BOLD is just, it acknowledges that we received funding from the building our largest dementia infrastructure from the Act, and other public health departments who either haven't applied or didn't receive it. But BOLD public health programs are those that did receive those funds. You are welcome. Well, thank you. If there are no more questions, we are going to wrap it up here. We will be sending all today's materials via email to all of you. They will also be available on our website. You can visit us there as well and get in touch with us. Send us an email, follow us on Twitter. And thank you for being here. And thank you, Victoria. Thank you, Haita, for a wonderful job, for a great presentation.
Thank you for having us.
And good luck on your application.
Thank you. Take care, everyone.
Bye.
Bye.